Hi everyone, I'm Sandus. I'm an ENT resident, and today we'll be talking about ENT infections, the one that we commonly see in the clinics and the emergency. So, without any further ado, let's start. We will initially start with the ear infections. We'll have a look at the anatomy of the ear, and then we will go into the common ear infections, definition, causes, clinical presentation, and basic treatment. So the ear is composed of three parts: the external part, the middle, and the inner part. As for the external ear, we have the pinna, and then we have, this is called the external auditory meatus, that will lead us to the middle ear. And in between the external and middle ear, here is the eardrum or the tympanic membrane. The middle ear will have the ossicles, the eustachian tube here. These are the important structures that we should know. And then the inner ear, which has the cochlea and semicircular canal, which are responsible for the balance. So this is the basic anatomy of the ear. Okay, so let's talk about the external ear. We said we have the pinna, which is basically a cartilage, okay? Except one part of it, which is the lobule. The lobule is here. It's soft. It has fat, and the place that we usually wear our earrings. So it doesn't have cartilage, just fat. It is very important to know that because we will correlate to it clinically later on. As for the external auditory meatus here, it is exposed to the environment. It has two parts, cartilaginous and bony part. So 1/3 of it is cartilage and 2/3 is bone. And it's very important to know that the cartilage of the external auditory canal the skin of it will have the hair and the glands that secrete the wax. Right. So the middle ear, we've got the tympanic membrane, which separates the external part from the middle part. And then we'll be talking about the ossicles and the eustachian tube. So when we insert the otoscope inside the ear, that's what we are going to see. And by the way, this is the right ear. So we see a very nice, healthy tympanic membrane, okay, with the cone of light that's reflecting here, and it is reflecting anteriorly. We can see the handle of the malleus, one of the ossicles. So the ossicles, we've got the malleus, the incus, and the stapes. So we can see the malleus very nicely attached to the eardrum, and we can see it here, the handle of it. And then the incus attached to the head of the malleus, and then the stapes, which is attached to the cochlea. Again, malleus, incus, stapes. Nice. The eustachian tube is connecting, it's a tube connecting the middle ear to the nose. The middle ear to the nose. This is a very nice tube. It's very, very important because it keeps the ear, the middle ear, nice, dry, and ventilated. Because in some situations where the eustachian tube is not functioning as it should be, it will cause fluid building up in the middle ear, and then it will cause like infections, problem hearing, etc., etc. And we call it otitis media with effusion, that we will be talking about later. Nice. Inner ear, it has the cochlea, semicircular canals responsible for balance. We'll not go into further detail of this. So just to know the cochlea and the semicircular canals. I think is enough here. Of course, it's nice to know more, but just for the purpose of this lecture. Beautiful. So this is very basic, nice overview. We've got the pinna, external auditory canal, tympanic membrane, ossicles in the middle ear, eustachian tube, cochlea, the auditory nerve, semicircular canals. All right, let's dive deep into the ear infections. So I divided them into the external infections and the middle ear infections. So we'll be talking about the common ones as well as the serious ones. So firstly, acute otitis externa. It is also known as the swimmer's ear because usually there will be a history of exposing to water, either it's pool, in the beach, whatever. It is inflammation of the outer ear, okay? And as I said, the outer ear is exposed to the environment, to bacteria, and that really put the external ear to a lot of infections. So we see it a lot in the clinic, honestly. What are the common causes? It's bacterial infection, most commonly Pseudomonas aeruginosa, as well as the Staphylococcus aureus. So as we said, the common risk factors, water, so humidity is one of them. Trauma, using cotton swab a lot. That's why we really, advise not to use cotton swabs because it can cause infections because of trauma. Earplugs, hearing aids, some dermatological causes like eczema, psoriasis, wax impaction, foreign bodies, patients or people who has low immunity will be at risk. Right, so the patient would present with ear pain, very, very painful. It is painful. Ear discharge, reduced hearing, that's really bothersome. And they will tell you like, oh, we just like been swimming or, using cotton swab. So there will be kind of history. It's clinical diagnosis, very, from the history, from the examination, just no, it is externa. And when you press on this part, which is the tragus, the patient will jump like from pain. Okay, so when you put the otoscope, what you will see whitish discharge, and sometimes you will see like very edematous erythematous canal that is sometimes is very severe, that's collapsing, that you cannot even see the tympanic membrane. In such cases, we will put what we call it earwick. It's like a piece of kind of tissue, like we put it inside. It's medicated. We put like on it like some ointment that help to open up the canal in order for the eardrops that we will be giving to reach to the whole auditory canal, and it makes it kind of working. We will advise to put cotton swab with Vaseline in order for the water not to get inside the ear, to help it to keep it dry, nice, and for the infection to resolve. Right, automycosis. So what is automycosis? It is fungal infection of the outer ear. So commonly caused by Aspergillus niger and Candida. So it is otitis externa, but it's fungal. For the risk factors, same as otitis externa, humidity, foreign bodies, cotton swabs, low immunity. All of these things are kind of similar, but the patient will present with itchiness more than pain. The pain might be there, discharge might be there, but it's more like itchiness because it's fungal. What you will see when you examine the patient, this kind of what we call fungal debris or fungal hyphae. It is white it's black dots that you will see it on top of the whitish discharge. It's very, very classic for fungal infection. And for the treatment, cleaning of the ear in the clinic with the section, because we want to make it very clean, and we put antifungal drops that usually from 3 to 4 weeks, because we know fungal infection takes time for it to resolve, and we'll see the patient, make sure the ear is nice and clean. Preconditis. So you remember we talked about the pinna and we said that it's composed of cartilage except the lobules. So we see here preconditis, it is inflammation of the cartilage of the pinna, sparing the lobule because it has no cartilage. What are the causes? Sometimes a trauma to the ear that will cause collection of the blood between the skin and the cartilage, and if it's not drained right away, the patient will have infection of the cartilage. Sometimes for patients who have high ear piercing that introduce bacteria to the cartilage and causes infection, sometimes it's part of it as external, especially if it's extensive, it can cause inflammation of the cartilage. As for the same bacteria that will cause otitis externa, and the patient would come with very painful erythematous pinna. It's really, really painful, and we will see it very obvious on examination. And when we see, it's very important that we rule out any collection that needs to be drained straight away. As we said, the lobule here, we have pinna preconditis, is spared. It's very important to distinguish it from other conditions like pinna cellulitis, where the whole ear is involved, even the lobule. So it's like soft tissue, not only the cartilage. Because the organism might be different and the choice of antibiotics will be different, so it's very important to distinguish between two conditions. So treatment of pinna preconditis. Antibiotics is the mainstay of treatment. Adequate analgesics. It's very, very painful, so we need to give the patient proper analgesics. If there's any collection, we need to drain it straight away, because we need to avoid any complications. And one of them is cauliflower ear, where the cartilage itself gets necrosed and it causes very devastating condition, deformed ear, cauliflower ear, which is deformed ear. It looks like cauliflower. It's cosmetically not appealing, so we need to treat the patient very, very properly to prevent such avoidable complications. Necrotizing or malignant otitis externa. So from its name, it's not cancer, but it is very serious and severe infection of the outer ear. Most commonly, a patient who has diabetes, low immunity, HIV, whom at risk of such severe condition. Patient will tell you, will present to the emergency or clinic with very unrelenting ear pain, especially at night. They will tell you, like, we cannot sleep, and they will usually be having ear discharge that's been going on for days, and they've been using ear drops, but it's not really working. On examination, when you put the otoscope, you will see like discharge granulation tissue inside. That is very, very classic for this type of infection. These patients need to be admitted. Blood tests like CBC, inflammatory markers, blood sugar, very important, because as we said, diabetic patients will commonly present with this condition, and we need to monitor their blood sugar, because that's what really put them at risk, right? We need to clean the ear, take biopsy of the tissue to rule out other conditions like cancer. Sometimes, or most of the time, we need to do imaging to assess the degree of infection And this patient will require actually, very long period of antibiotics. And of course, blood sugar control. Very, serious infection needs to be treated properly. Patient needs to be evaluated again and again to make sure there's no remnant or recurrence of the infection. Okay, so let's move to the infections of the middle ear, starting with acute otitis media. So it is an infection of the middle ear. Mostly seen in pediatrics. We see it a lot. It is, one of the common causes of ear pain in pediatrics, especially with the common cold. Most commonly, it's viral, but it can be bacterial, and the most common one is Streptococcus pneumoniae. Parents will tell you, our kid is just, he keeps pulling the ear tugging, he's irritable, not really eating properly, all of these symptoms, fever, that will indicate there's some infection in the ear. And when you examine the ear, you see here, we've got nice grayish, transparent tympanic membrane. But here you can see bulging erythematous tympanic membrane, indicating there's collection inside the middle ear, pushing the tympanic membrane. Sometimes they will present with a hole, and there is draining pus from the middle ear. We need to treat it with augmentin or high-dose amoxicillin. And if there's perforation and there's pus discharging from the middle ear, then we would also include some topical antibiotics ear drops. We need to control the pain. If there's any fever, very, very important. Chronic otitis media. So when do we actually call it chronic otitis media? When there is ongoing chronic infection of the middle ear, more than 2 to 6 weeks, and there's a history of a hole in the middle ear. So what are the risk factors? Patient who has frequent episode of acute otitis media might get chronic otitis media. Patient who has tubes inserted to treat an infusion in the middle ear, they might get chronic otitis media. So they will have ongoing ear discharge from the tube. Patient who has cleft palate, Down syndrome, patient who has previous ear surgery. So the patient would present with painless ear discharge, maybe history of previous ear infection, history of ear surgery. And on examination, you will see there's a hole, and sometimes there's discharge, sometimes there's no discharge, but there's a hole in the tympanic membrane. How do we treat it? With topical antibiotics, topical ear drops, and also we need to make sure there's no water going inside the ear. So we tell the patients to put cotton with Vaseline while they're taking shower. That would help to reduce the number or reduce the infection that's going on. If this doesn't help, they might need a surgery like tympanoplasty, which we put a graft to close off the hole in the ear. Otitis media with effusion. It is a fluid in that middle ear space, which is not supposed to be there. As we said, the middle ear space should be nice and well aerated. What is actually happening? So the eustachian tube that we said it is responsible for ventilating the middle ear, which is connecting the middle ear to the nose, sometimes, and especially in pediatrics, is not really functioning very well. So that will create negative pressure in the middle ear and accumulation of fluid. So the fluid cannot be drained because it is not really functioning. And the risk factors are really smoking, secondhand smoking, especially if the parents are smoking, if the patient has cleft palate, if they are feeding what they are supplying, they are that can really put them at risk to have fluids. So family would actually report hearing concern. They would tell you like, we call him, but he's not really paying any attention. Speech delay, low academic performance at school. That's very common presentation. And when you put the otoscope, you will see there's cloudiness of the tympanic membrane. It's not the usual color that we see. There's some bubbles there. So that indicates there is fluid inside. Hearing tests is very important that we do it to assess the hearing level, as well as tympanogram. And the tympanogram is basically they assess the mobility of the tympanic membrane, and if there's a fluid, it will not be mobile, so it will give a flat line that will indicate, and we call it type B, that will indicate there's effusion. Type A is normal, so it has some nice peak there. So for the management, if the history is less than 3 months, so we would just observe, so watchful waiting, and most of the time that it will resolve on its own. So, we would advise them to avoid exposing the kid to smoking. If they're feeling worse upon, then we advise them against that. So try and reduce, the risk factors or modify the risk factors. However, if it goes beyond 3 months, so we'll follow them up, we'll do hearing test again, and if it goes beyond 3 months, so then we might need to surgically intervene, and we put a tube in order to resolve the fluid. And also, if it's really affecting the hearing, the speech, the language, there's language delay, and also if there is cleft palate, in such cases, it's very important we insert a tube in order to resolve effusion and help with hearing, with the speech, etc. Finally, for the middle ear infections, we've got the acute mastocytitis. And what is it exactly? So it is a complication of acute otitis media. And acute mastocytitis is inflammation of the mastoid bone, which is here behind the ear. This is the bone that we feel it. This is the mastoid. It is a serious infection that needs proper attention. And the risk factors including kids that are less than 2 years, who has low immunity, who has recurrent acute otitis media, incomplete pneumatization of the mastoid bone. So all these are risk factors to have such complication from the otitis media. So the kid will present, he will be fuzzy, irritable, lethargic, high fever, pulling the ear, so very kind of or more severe form of otitis media. It's not like just simple one. The symptoms will be more severe. And on examination, you will see there is erythema and bulging of the mastoid or the postauricular area. And the pinna itself will be protruded and displaced anteriorly and inferiorly. So, and when you examine the ear, sometimes you will see there is bulging of the tympanic membrane, indicating there's a pus in the middle ear. So, patient needs to be admitted, treated with IV antibiotics, steroids, and we also insert a tube inside the ear in order to resolve the infection. And we do labs also, CT scan, very important. So, and then we will monitor within 48 hours with all of the medical management. If still there's symptoms, we need to actually do mastoidectomy, where we drill the bone and get the pus out. So we need to treat it very properly, because it might go in the brain, causing meningitis, brain abscess, cerebellar abscess. So we really don't want to reach to that level. It's very important that we treat it properly and we monitor the patient along the way. Right, so now we will move to the nose. So nose and paranasal infections. And the first one, very common cold, okay, who doesn't know it? It's viral infection of the upper respiratory tract, affecting primarily the mucosa of the nose. And it's viral, commonly rhinovirus. Symptoms like cough, sore throat or pharyngeal pain, stuffy nose, low-grade fever, general malaise, all of these viral symptoms. Usually it resolves within, 10 days, and sometimes it may last to 2-3 weeks. Management, hydration, antihistamine, saline irrigation of the nose, decongestant, especially, it's very important that we don't use it more than 5 days, because it might cause some rebound symptoms where when you stop it, the symptoms might come back. So just, um, um, hydration and analgesics and saline irrigation. For acute rhinosinusitis, now the sinus that we have, let's talk about the sinuses that we've got. So we've got 5 sinuses. We have the maxillary, okay. We have the ethmoid. We have the frontal, and then we have the sphenoid. So we have 5 sinuses. What happens is that the patient might have just common colds, and then it will get swollen and the sinuses will be involved as well. So, as you said, it starts with a common cold, the mucosa will get edematous, and then it will obstruct these sinuses. So it will have, the patient will get, pressure. They will tell you like, we've got some pressure, especially when they bend forward, and then they will have a history of common cold. Typically, it resolves, less than 4 weeks, and it is caused by viral infection. However, it can be bacterial, especially if we have high fever, if the patient reports improvement and then they will get worse, so they will improve and then they will get worse, that's a sign of a bacteria. If they have unilateral nasal discharge, colored nasal discharge, severe pain, and when you do blood tests, it's, they have high inflammatory markers, that will actually indicate there is some bacteria going on. So if we have 3 of this, fever, if they have double skinning, unilateral, severe pain, raised inflammatory markers, any 3 of this will indicate this is not just viral, no, it is bacteria. And in such cases, in bacteria, we need to actually give antibiotics, right? So as we said, it starts with viral infection, and then the mucosa will get swollen. That would actually cause inflammation of the sinuses. And sometimes it might be just, viral, but if it doesn't resolve, then the bacteria will infect the sinuses and will have bacterial rhinosinusitis. So if it's just viral, then we will give, saline douching, decongestants, steroids. However, if it's bacterial rhinosinusitis, then we will involve antibiotics as well. Because sinusitis, bacterial sinusitis, it can cause some complications, like it can go to the orbit, to the eye, and it can cause orbital cellulitis, orbital abscess, even it can cause some problems, brain abscess, etc., etc. So it's very important that we treat it properly with antibiotics. Right, so let's move to the throat infections. So we've got the acute pharyngitis or tonsillitis. It's basically inflammation of the pharynx and the tonsils. Mostly are viral, but it can be bacterial, especially we've got the strep throat, streptococcus tonsillitis, which accounts for 25% in children. How would they present? Sore throat, fever, difficulty swallowing. You will see congested throat, enlarged tonsils. Sometimes you will see this exudate that will indicate it is, bacteria. So if it's just viral, we will see congestion of the pharynx as well as the tonsil. So just congestion. There's um, no pus involved. However, if it's strep or bacteria, then we will see exudate and pus on the throat, on the tonsils. Um, Also, there are some signs and symptoms. They might indicate it's bacteria. So if it's high fever, there are exudates or pus on the tonsils. If there are tender lymph nodes, then it might be bacteria. However, if it's just, if there's any cough, some eye symptoms involved, rhinorrhea, so it is just viral. So symptoms are very important. So we've got some criteria which is called center criteria, and it basically will tell you whether it's viral or bacterial. So do we actually start antibiotics or not? So it has 4 points. So if there's no cough, that's 1 point. If there is tender nodes in the neck, that is 1 point. If the fever, high-grade fever, that's 1 point. And if there are exudates, that's 1 point. So if it's a 3 or 4, then we will start antibiotics usually. And if it's, less than that, then we can just, we don't need actually antibiotics. Pretonsillar abscess, or it's called quinsy. So basically, it is a collection of pus in between the tonsils and the pharyngeal muscle. So it is not just tonsillitis. Now we have some collection between the tonsil and the pharyngeal muscle, and it is a complication of tonsillitis, and the patient will be sicker. Okay, they will have trismus where they cannot open their jaw. They will have pain on swallowing, drooling of saliva. They cannot really swallow their saliva. Their voice is like very muffled. They have high-grade fever. So, and when you examine these patients, what you will see here, this is the uvula. You can see it is pushed to the side. It's not in the center. And here is the bulging of the tonsil. It's bulging and it's pushing the uvula to the other side. So indicating there is some collection there. It's very, classic. You can see it. You can tell there's an abscess there. So patient needs to be admitted, start on IV antibiotics, steroids, IV fluids, and we need to actually aspirate and we drain the collection that's inside. And we send it for culture and sensitivity in order to adjust the antibiotics according to that. Acute epiglottitis. So what is acute epiglottitis? So we've got the epiglottis, which is basically a part of the larynx, which is responsible for the voice. So it is the upper part of the larynx. It's called epiglottis. It is actually a serious infection that affects the epiglottis and the nearby structures. It is very, very serious. It's a life-threatening condition, okay? Because it can actually impede the airway because it is sitting on the airway, the larynx, and when it gets inflamed, I will show you at the picture in a minute, it can actually cause obstruction of the airway. So it's very life-threatening emergency. Now, the good thing that the incidence of such infection has been decreasing because of the vaccination of the Haemophilus influenza type B, which is the main organism of this infection. So it is, we don't really see it that much. We rarely see these infections. Non-infectious causes like trauma to the epiglottis, like burn, acute leukemia, there might be a causes for epiglottitis. So patient will present with drooling, they cannot swallow their saliva, dysphagia, stridor, there will be in respiratory distress, and then they will have this classic tripod position where they sit and their mouth is open, their neck is extended, and they are leaning forward, they're gasping for air. They do this position in order to, get the air inside. These patients need emergent attention and management. So we should avoid any examination, like throat examination, because that would really cause them to get irritable and the airway might close off. So we need not to do an examination at all until we secure their airway. So the airway is a priority here. We need to take them to the OR, secure the airway, and we take swab and send it for culture. And then we can examine them after that. And when we do the X-ray for these patients, we will see the thumb sign here. The epiglottis it's like, the thumb. It's like doing thumb sign on the lateral neck X-ray. And this is the epiglottis, okay? As we can see, this is the epiglottis and this is the airway. So this is the normal and this is the epiglottitis. You see it is significantly inflamed, which is causing obstruction of the airway. That's why we really need not to examine the patient. We need to intubate them, put them in the ICU, monitor them, start them on antibiotics until they improve. So, as I said, after securing the airway, they need to be admitted to the ICU, IV antibiotics, steroids, and then if they meet the criteria for extubation, then we can extubate them. So avoid placing them in supine position, and we need to minimize unnecessary intervention. Finally, we've got croup. So croup is a common respiratory condition in younger pediatrics. So if they are less than 6 years, the peak incidence between 6 months and 3 years. It's very common, and it affects the whole airway, the larynx and the trachea and the bronchi. So we can see here, this is what we call steeple sign. It is narrowing of the airway, right? So let me remove here and then we can see it again. So this is the airway and here it's very narrow. This is called steeple sign and it's very common, it's very classic to see it with these patients. So parainfluenza virus, so it's viral. And what is the presentation? Kids will present with barking cough, very, very classic, stridor, and in severe cases, they will be in distress, especially at night. They will be having nasal flaring, chest retraction, and sometimes in severe cases, they may get cyanosed. Treatment will basically depend on the severity. So if it's mild, like they're just having the barking cough and the stridor, just when they get agitated, they're not really in distress, then we just give them single dose of dexamethasone. So and then supportive gear like hydration, etc. However, if they are in severe respiratory distress, like they're having stridor, respiratory distress, then we should give them nebulized epinephrine and dexamethasone as well. And then they improve, very nicely. So that is for, this is the last infection that we will be discussing today. So I put for you guys some questions, and 5 questions, right? Here the second one, the third one, the fourth, and the fifth. And then we've got the answers. So let's do them together. The first one, otitis externa is commonly associated with except. So, is it associated with auricular pain and tenderness, history of swimming, need for oral antibiotics, need to be treated with topical antibiotics? So which one? I will let you guys do it. Okay, so I'll move on to the next question. So most common pathogen associated with otitis externa, is it Pseudomonas aeruginosa and Staphylococcus aureus? Is it fungal, Streptococcus pneumonia, or Haemophilus influenza? We actually talked about it, if you remember. So which one? Let's move on. The diagnosis of otitis media mainly depends on audiogram, radiological studies, history and physical, or hearing aids. This one is very simple as well. So let's move on. Which one is not a sign of acute bacterial rhinosinusitis? If you remember, guys, so is it purulent nasal discharge, fever more than 38 degrees, double sickening, improvement of symptoms within 10 days? So which one is not a sign? That one we also mentioned. Finally, in a patient with epiglottitis, which option is most accurate? Avoid throat examination before securing the airway. Only treated with analgesia and anti-inflammatory. Securing the airway is not necessary. It is a common infection. So which one is most accurate from these listed options? You know, I emphasize on that, so it should be very, very straightforward. And we've got the answers in the next slide. I hope you guys really enjoyed it and learned from it. And thank you so much.